This is DPT 766, Differential Diagnosis for the Physical Therapist. The content in this lecture will cover screening in special populations. Take a moment to pause and review the outlined objectives. In this lecture, we're going to discuss some special considerations, screening needs, and appropriate screening questions and tools for the following special populations: pediatric and adolescent patients, obstetric patients, geriatric patients, and post-surgical patients. We're also going to touch base on some specific pathologies and conditions that would be appropriate to screen for in each of these populations. So up first, we have the pediatric and adolescent population. A few considerations to keep in mind before we jump into the specific pathologies include making sure that you ask the patient and caregiver what their preference is for the presence of the caregiver during the examination. It's important to understand and get consent whenever we're working with children, but it's also, we may need to consider potentially how the patient will respond. The patient may respond better if the parent isn't present, but we want to make sure that we are consistent with what the preference is in regards to having that caregiver present. Another thing to keep in mind is that we want to make sure that we don't talk around the patient, that we talk to the patient as much as possible. So we want to ask our questions to the child or adolescent as much as we're able to, and then refer to the parent if necessary, if we need to fill in some gaps. But we want to make sure that we're hearing as much firsthand information as possible. And then otherwise kind of checking in with the parent to make sure that the information is complete or that we're not missing any other specific details that would be important to the case. We also want to keep modesty in mind, especially if we think about teenagers. We may have a teen that would be uncomfortable removing a shirt in an open gym area, whether that be male or female with a sports bra on. So we want to be sensitive to this stage in life when our patients are going through puberty. Lots of different changes are occurring in their bodies and they may feel uncomfortable. So it also may be appropriate to ensure that the caregiver or another healthcare provider is present if we are having to examine a sensitive area with our patient. So now let's talk about a few pathologies to keep in mind in this younger population. The first is meningitis, which occurs when we get inflammation of the membranes or meninges surrounding the brain and the spinal cord. The majority of the time, these are caused by viral infections, but other causes can include bacterial and fungal infections, which of the three, bacterial infections are the most dangerous. 20% of cases occur in individuals that are between 14 and 24 years of age. And what we would suspect the hallmark signs to be include fever, headache, and a stiff and painful neck. So you could see we could very well have a patient that is coming to us for complaints of headaches or complaints of neck pain. So it's important to kind of recognize and look for these hallmark symptoms, specifically if we have patients with the following risk factors, including skipping vaccinations, those that are 5 years or younger than 5 years old, people that are under 20, but those that are living in community settings like a dorm room, military base, or boarding school, patients that are pregnant, and then finally those that have compromised immune systems. It can be really easy to mistake the early signs and symptoms of meningitis for the flu. So we just want to keep these hallmark signs in mind and make sure that we refer appropriately and immediately if we're concerned a patient may be presenting with meningitis. Neoplastic disorders include bone tumors. So benign tumors usually aren't going to cause severe pain that would be associated with an individual that had a malignant tumor. Oftentimes, these can manifest as a pathologic fracture with signs and symptoms indicating that there is some soft tissue swelling, the patient's reporting tenderness, maybe joint pain if the tumor is near a joint, the presence of a mass without the history of a trauma, and then lastly, night pain, pain unrelated to position, fever, weight loss, night sweats, and fatigue. So now we're going to talk about osteochondrosis, which is avascular necrosis of the epiphysis. This occurs in the immature skeleton, and it's an idiopathic disorder. We note that it's most common when the individuals are between the ages 3 and 10 years of age. It affects boys more commonly than girls. We also note that it's more common in the lower limbs than it is in the upper limbs. And lastly, that the presence is bilateral about 10 to 15% of the time. So now we're going to talk about some specific osteochondrosis conditions. The first is Legg-Calvé-Perthes disease. This is the most common and serious of all of the lower extremity osteochondrosis diseases. The involvement here includes the epiphysis of the proximal femur. Again, we see boys are more likely to be affected than girls at a ratio of 5-to-1. Caucasians are more likely to have Legg-Calvé-Perthes disease than African Americans at a ratio of 10-to-1. We would note that this occurs most commonly between the ages of 4 years old and 8 years old. And again, we see it bilaterally about 10 to 15% of the time, with the cause being unknown. The symptoms that we would expect to see include limping, pain or stiffness in the hip, groin, thigh, or knee, as well as limited range of motion of the hip joint. The treatment goal here for individuals that are diagnosed with Legg-Calvé-Perthes disease is to maintain the femoral head and the acetabulum, and this is done through a series of abduction serial casting. Next up, we have Freiberg's disease. This is osteochondrosis of the metatarsal heads. The patient would most likely report forefoot pain with weight bearing here. This one is more common in females, and it may occur secondary to an individual that has a long second metatarsal or a short first metatarsal. In this case, the treatment would include shoe modifications to redistribute the weight. Occasionally, an individual may have to have surgical excision of a distorted proportion of that metatarsal head. Panner's disease is osteochondrosis of the capitulum of the humerus. Anytime we have a patient that's between the ages of 3 and 11 that's presenting with pain, swelling, and limited range of motion in the elbow joint, we want to have Panner's high up on our list, and we want to make sure that we are able to rule that out. Treatment would include immobilization in a sling when a patient is in this symptomatic period, and the prognosis is really good given the non-weight-bearing nature of the elbow joint. Up next, we have Kienbock's disease. This is osteochondrosis of the lunate. A patient presenting with aching in the wrist, tenderness over the lunate, and swelling secondary to repetitive microtrauma would be of concern in regards to Kienbock's disease. It presents oftentimes in late adolescence and young adulthood. Healing here is slower in adults compared to children because of the blood supply there. And then also treatment would include excision of the lunate bone before degenerative changes develop in the surrounding carpals. Moving on, we're going to talk about some disorders of epiphyseal growth. A slipped capital femoral epiphysis, or SCFE, is another common hip disorder that's seen in adolescents. Here, the age group that we're likely to see this in would be males that are 13 to 16 years old, and they're 2 times more likely to experience a SCFE in comparison to females. And in regards to females, the age range we typically see this at would be 11 to 14 years old. Risk factors include obesity, individuals that are African American, and then lastly, children that have endocrine abnormalities. This is the most significant lower limb epiphyseal plate disorder. Sometimes it can be missed due to reports of knee pain being the chief complaint if the hip is not examined. The clinical presentation includes limping that's increased with fatigue, pain in the distal thigh or knee. They may have some mild hip pain, and we would note that they would prefer to be in a position of hip flexion, external rotation, and abduction. Individuals with a SCFE typically require surgical pinning in order to repair the slipped capital femoral head. Another disorder of the epiphyseal growth includes adolescent idiopathic scoliosis. This develops during pediatric years, and onset we typically note in puberty. It's the most common form of scoliosis, which is just a lateral curvature of the spine. Here we see that it's going to be more common in females. And in order to test for scoliosis, what we would have the patient do is perform the Adams forward bending test. This is what's utilized as a screening tool. And you'll see that over to the right. Basically, with the Adams forward bending test, we just have the patient lean forward to touch their toes. A normal spine would look like what we see here, whereas an individual with scoliosis would have what we would call a rib hump, and we would see some of that curvature in the spine as well. Individuals that have scoliosis would be surgical candidates if the curve progresses past 45 to 50 degrees. And in that case, the reason for surgical correction is because the rib cage can at that point then compromise the cardiopulmonary system, and that can result in obviously some very negative side effects. If we have a patient that has suspected scoliosis, they should be medically evaluated if their physician is unaware. In regards to how we name scoliosis, there are two different types, either a C-curve or an S-curve. So a C-curve is kind of where we have an individual that has just a curve in one part of the spine, whereas an S-curve would look just like an S, and they would have the curvature in multiple parts of the spine. And we would name it by, again, the shape. So is it a C-curve or an S-curve? The location, as well as the location in regards to, is it in the thoracic spine, the lumbar spine, etc., and then the direction of the convexity of the curve. Myositis ossificans occurs when we have the formation of heterotopic bone within the muscle. Oftentimes we note that this would occur as a result of a complication of a severe or poorly managed contusion. Most oftentimes we see this occur in the quad or in the biceps brachii muscle bellies. And you know, an example of a mechanism of injury might be a kid that's playing football, and maybe they're at practice and they're playing football without their pads on, and they get hit in the thigh. So that results in a contusion, and if it's poorly managed or if it's severe, it can progress to myositis ossificans. Warning signs of a severe contusion include an individual with marked decrease in the range of motion, significant pain, joint effusion, and then lastly, decreased function. Here we'd want to watch for a palpable mass at the site of injury that can show up several days post-injury. So here we want to be aware of myositis ossificans in adolescent athletes that we may be treating for a contusion. Important to recognize that common causes include failing to apply cold therapy and compression immediately after the injury, and or applying heat too soon. Ice can help to reduce the pain, inflammation, swelling, and encourage the injured muscle to heal. Also, if an individual has very intensive PT or massage too soon after a contusion, that can increase internal bleeding and prevent healing. Next up, we have the female athlete triad. This relates to the relationship between available energy, menstrual function, and bone mineral density. And it can result in a adolescent having disordered eating, resulting in energy deficiencies, amenorrhea, and osteoporosis. If we're concerned that an individual may have the female athlete triad, we want to think about some of the clues that would indicate that we would need to screen further. One includes a low body weight. The second is if they have a current or past stress fractures. Especially if we're seeing repetitive stress fractures. And then also participation in sports that favor lean body size or that have weight classes. So gymnastics, figure skating, distance running, long distance running, and dancing. Further screening questions that we would want to include if we're concerned that a patient may be suffering from the female athlete triad include when was your last menstrual period? This can give us indication if they are menstruating regularly. Do you skip meals? That can give us information in regards to how they're eating. Have you ever been treated for a stress fracture in the past? And then how often do you train and exercise, as well as, you know, when do you rest and recover? These are all questions that can help us to identify. And then last up for our pediatric conditions, or we're going to talk about heat illness. So it's important to recognize that children don't acclimate to heat as well as adults do because they don't have the ability to dissipate the heat as we do as we get older. So you'll note that the ability to dissipate that heat does improve as a child moves into adolescence. But it's important that we watch for the signs of heat illness in both of these populations. So this would be pertinent to a physical therapist that may be working with a sports team, or let's say that you are working with a kid and you maybe have them outside in the heat when you're performing some more sports specific activities as opposed to being in a controlled environment like a clinical setting. In order to prevent heat illness, we would want to encourage kids to limit playing in really hot and humid conditions, specifically for very long periods of time, and also ensure that there's adequate fluid intake. So there are 3 different types of heat stress disorders, and they include heat illness, heat exhaustion, and heat stroke. Heat illness would present as the child becoming thirsty. They have chills, clammy skin, cramps, nausea, muscle twitches, and weakness and fatigue. Here, it would be important for treatment to include having them drink a half a cup of water for every 15 to 20 minutes and rest in the shade during breaks and to remove any extra clothing. Heat exhaustion is more severe. Here, we note that the child may stop sweating, that dizziness may be present, headache, shortness of breath, lack of saliva, extreme fatigue, weakness, weak rapid pulse, lack of coordination, as well as thirst. In this case, we want to stop the activity and move the child or adolescent to a cool place, have them drink 2 cups of water for every pound lost, which would be difficult to know exactly if you're not weighing them on the sidelines, but or encouraging them to drink more water is the ultimate goal here. And then remove wet clothes and sit in either under a cold shower, under cold water, or in a cold, if you have any other access to cold water on the field. In regards to heat stroke, this is defined if a individual has a temperature greater than 105 degrees. We would see symptoms including lack of sweat, dry, hot skin, lack of urine, hallucination, swollen tongue, deafness, aggression, ataxia, high temperature, seizing, vomiting, rapid heart rate, and diarrhea. This is a medical emergency, and we must have the individual stop activity, move them to a cool place, call for an ambulance as well, and put ice bags on their head and back until help will arrive. And in this case, if they are not alert, we would not want to give them water because aspiration is possible. So if they are, kind of passed out, in that case, we would not want to give them water. If they're alert and able to drink, then we would want to have them drink water if they could, but we just want to be mindful of that. Now, all of these things can occur in any individual, but just as it relates to working with pediatric and adolescent population, they would be at greater risk. So it's important to recognize the signs and symptoms and respond appropriately.